So it's a pleasure to, at the end of the proceedings, last lap, graveyard slot, call it what you will, Dr. Rob Ryder, thank you very much for picking this one up. We're talking about combination therapy and where this fits in into the big scheme of things from what we've heard.
So now we get to the talk. So here we are, as we say, the graveyard slot, which means all these incredibly brilliant people have already spoken. I always start off, I love these couple of slides. The WHO definition of diabetes mellitus in 1980. Diabetes mellitus is a state of chronic hyperglycemia, which of course is how the world still thinks about it. It's about hyperglycemia. And then there was this redefinition by our friend Miles Fisher at the British Diabetic Association, 1996. Diabetes is a state of premature cardiovascular death. To make sure we understand what the main problem is, which is also associated with hyperglycemia, so we have that, and also associated with the microvascular complications, but this is the big problem. And of course, this is the lesion, and this is data we heard today about all the ways in which we can stop it happening now with particularly lipids and blood pressure, but this is data from a long time ago showing that a man who isn't protected with statins and antihypertensives and things, diagnosed with diabetes in his 40s, is going to live 10 years less than his friend next door of the same age who hasn't got diabetes. So the problem with me in my slot is that when I had to hand these slides in first thing this morning, I did not know when these slides were made, but what piece was already going to have been said, but from the titles of the programme, I'm going to assume that you've already been shown from studies so far, as they say in strictly in no particular order, that you've been convinced by Cliff that from the UK PDS, metformin improves cardiovascular outcomes. So I'm taking that as a given. And I was also there for the UK PDS, incredible event again, and it surely arguably the greatest study of all time. Published on the day as they stood on the stage in Barcelona presenting this data. It was published at the same time in 3 papers in the BMJ and 2 in the Lancet, and I gather that Richard was involved in facilitating that happening. And these days, you know, what do they get? It's just published in the New England Journal on the same day, 1 paper. So I suggest it was the greatest occasion. There's Robert Turner. Photographs taken by me, and these are the great famous people: Robert Turner, Rory Holman, David Matthews, Alex Wright. And of course, this is the slide, the actual UK PDS slide, that showed that metformin reduces all-cause mortality and myocardial infarction, the only medication that did that in UK PDS. And then 10 years later, we've already seen these slides, showing the separation continues and continues over 25 years between conventional therapy and metformin. So I'm also going to assume that from various speakers today, we know that 3-point MACE is a combination of cardiovascular death, myocardial infarction, and stroke. And that if these are less added together in the treatment arm compared to the placebo arm, then we assume benefit. And I'm going to suggest from the following 4 slides that you've already seen that diabetes patients at high cardiovascular risk, empagliflozin reduces cardiovascular outcomes. And you've seen these slides, so I won't stay with them. Primary composite endpoint, 3-point MACE, cardiovascular death, led by cardiovascular death. We've already established that, with the other things not being statistically significant, indeed stroke going the other way. And I'm going to assume that you've been convinced that the findings of EMPA-REG are reminiscent of those of Ephesus heart failure study. That actually hasn't been mentioned, I don't think, which suggested a hemodynamic mechanism for the impact on cardiovascular death and heart failure. So this is the data from the Ephesus heart study with the eplerenone showing immediate separation of the lines for heart failure and similarly for death. And this is very similar to that for empagliflozin. It's the heart failure immediate separation of lines. And I'm going to suggest that you've also been convinced that except for peripheral vascular disease findings, the findings for EMPA-REG and CANVAS are very similar, suggesting a class effect with similar mechanisms for SGLT2s. So this is the primary composite endpoint for CANVAS and EMPA-REG side by side, showing very, very similar outlines, and for heart failure, almost identical from the two studies. And I'm going to assume that you've been convinced from the results of LEADER that a prescribable GLP-1 receptor agonist, liraglutide, improves cardiovascular outcomes in patients at high cardiovascular risk. And here's the primary composite endpoint, very similar hazard ratio to EMPA-REG, and cardiovascular death, even more so, as in EMPA-REG. And I'm going to assume that you've also been convinced that another long-acting GLP-1, not yet available for prescription, semaglutide, also improves cardiovascular outcomes, though it may worsen established retinopathy, which that hasn't been talked about, and I have a slide on that if anyone wants to talk about it, but we think it's just the rapid improvement in hemoglobin A1C, which we've known forever can worsen established retinopathy. What about was Excel? I wasn't sure what was going to have been said about Excel. I've got my view of Excel, which I'm going to show you now in a couple of slides. So this is LEADER, cardiovascular outcome study with liraglutide, Excel with exenatide QW, both long-acting GLP-1s. And this is looking at the main results from the two studies side by side. And my view, as was Rory Holman's on the day, is that the pattern is actually very, very similar. Primary composite endpoint dragged that way, cardiovascular mortality. They're all sort of similar, but not achieving statistical significance in Excel, whereas in LEADER, it did achieve statistically significance, but it was nearly there, 0.06, and all-cause mortality was statistically significant in Excel. And the number needed to treat to save one life was 98 in LEADER and 106 in Excel, very, very similar. So I think you can explain that result by the differences between the study, in that the LEADER patients were at higher cardiovascular risk, and there's a paper by myself and Ralph DeFronzo in which I actually show that data, but the LEADER patients had longer exposure to study medication. It was only 2.4 years in Excel, 3.5 years in LEADER. Excel had a 43% premature discontinuation of study drug, huge discontinuation of study drug. And if you remember that great big scandal about GLP-1s causing pancreatic cancer and pancreatitis that was in the BMJ and in this country anyway, and the Dispatches documentary program, and was in the newspapers, and lots of people now became scared of this agent, and I think this probably was one of the things that drove people just refusing to take it anymore. And of course also the original pen for exenatide QW was quite hard to use, so a lot of discontinuation. And there was also a high use of other drugs which we now know improve cardiovascular outcomes in the placebo arm. So it may be all these together led to the fact that Excel wasn't statistically significant. And in fact, online ahead of print at the moment, myself and Ralph DeFronzo are saying everything I've just said. So nevertheless, I think despite that, if we're going to prescribe a drug that needs for patients at high cardiovascular risk, and it's a GLP-1, we have to use the Proven one rather than the unproven one. So even though it's likely to be a class effect, if you've got to sit there and choose with your patient in front of you, I think you'd go for liraglutide first. And I'm finally going to assume that you've been convinced that metformin, SGLT2s, in particular empagliflozin and canagliflozin and liraglutide, all improve cardiovascular outcome in diabetes patients at high cardiovascular risk. I'm also going to assume that nobody said anything about pioglitazone, and hence I have a role. And it's not quite true, because I think Lars did say some words in defense of pioglitazone. So there we are, I was there, and I'm Dr. Bob Ryder, and I'm a being at the presentation of the cardiovascular outcomes studies aholic. So it started with my first shot, which was the DCCT, and if I'd left it there, I'd probably been all right. But then came the UK PDS, and really I was now an alcoholic. And this is what I've been to since. And it's really all of them. Everyone is the incredible adrenaline rush, you know, what's it going to show? And then the intense disappointment or extreme pleasure. I mean, it's... and we've heard about all of them today except for this one. And so now I'm going to say a few words about this one. And here's the pictures I've took at all of them, the crowd milling and then the full place. And this is a picture of the crowd 5 minutes before 5 to 5. I took a picture of the crowd, and there's my place, empty place in the front row, because I went there 3 hours before to make sure I was in the front row. I was so excited. And then some Europeans who were pissed off that the room was full came and put their chairs in front of the front row. And with 2 minutes to go, there was an entire new front row. And we tried nudging them in the ribs and things, but it made no difference. And this is Professor Dormandy, who was the leader of the study. And potentially the fact of his leadership was part of the problem because he was a vascular surgeon. And here we are. Proactive study. So they randomized 5,000 odd patients at high cardiovascular risk because they'd had a previous event into half who would have Pioglitazone and half who would have placebo. And these are the results. So if we look at the primary composite endpoint of not the primary composite endpoint of proactive, but the standard primary composite endpoint of 3-point MACE, there was a statistically significant reduction, hazard ratio at 0.84, statistically significant, no question, this agent reduces cardiovascular outcomes according to 3-point MACE. If you look at, from proactive people who've had an MI, what are their chances of having another MI if they're on Pioglitazone versus placebo? Statistically significant reduction in your chances of having a second MI if you've had one and you're on Pioglitazone. And what's the one thing you don't want to happen if you've had an MI? You don't want another one. Even more so with stroke. If you've had a stroke and you take Pioglitazone compared to placebo, look at this massive reduction in the chance of having another stroke, this huge p-value. And if you've had a stroke, what's the one thing you don't want? It's another stroke. They did a randomized controlled trial of Pioglitazone versus glimepiride, looking at carotid artery intermediate thickness, a marker of coronary atherosclerosis, which independently predicts cardiovascular events, and found that Pioglitazone slowed the progression of coronary artery intermediate thickness. In the randomized controlled trial of Pioglitazone against glimepiride, looking at intravascular ultrasonography, found a lower rate of progression of coronary atherosclerosis as assessed by intravascular ultrasonography, the Periscope study. If you look at a meta-analysis of randomized controlled trials, 19, Pioglitazone receiving patients showed a significant reduction in death, myocardial infarction, and stroke compared to patients receiving control therapy in a meta-analysis. And this is interesting because, of course, the meta-analysis everybody knows about is the rosiglitazone one. And this is the same meta-analysis with Pioglitazone showing cardiovascular benefit, where the rosiglitazone one suggested cardiovascular harm. And we heard earlier that the IRIS study published last year, which was in patients without diabetes who had high insulin resistance and had an ischemic stroke or TIA, had Pioglitazone versus placebo, and the risk of stroke or myocardial infarction was reduced by 24%. So it does seem that there's overwhelming evidence that Pioglitazone is an agent of cardiovascular benefit, but confused of Hatter Horizon Series meeting 2017, who knows his stuff, might say, but I thought the proactive study showed no cardiovascular benefit for pioglitazone. And that is because of the so-called primary composite endpoint of the proactive study. And that's the only piece of evidence that raises any possible doubt that pioglitazone is associated with cardiovascular benefit. And so let's have a look at this endpoint. There we are, the patients were randomized, and this was the primary composite endpoint. And I think that the people doing the study were hoping to be clever and increase their chances of its success by, instead of just having your standard 3-point MACE, to add in a few other things. And it all backfired. And this was the slide of the primary composite endpoint. There was separation of the lines, but it didn't achieve statistical significance. And this is the reason why the world didn't hear about proactive, whereas the world heard all about the rosiglitazone meta-analysis, because it was on the 6 o'clock news, and the whole class got dragged down by that. So let's have a look at this primary composite endpoint. Here it is. Here are the factors. And if we look at these ones here, this is the pioglitazone group, this is the placebo group, and you see that each of these things in the endpoint were less in the pioglitazone group. Death was less, non-fatal MI was less, silent MI was less, stroke was less, major leg amputation was less, acute coronary syndrome was less, and if you do the stats on those numbers, it's highly statistically significant. But the statistical significance is entirely lost by the bottom two lines. There were the same number of coronary revascularizations in the pioglitazone group compared to placebo group, and more leg revascularizations. And these were much bigger numbers, and so add these numbers into the whole, and statistics doesn't, it's just a maths calculation, which meant it wasn't statistically significant because of these. Now, the question is, if pioglitazone is reducing atheroma and improving what's going on inside arteries, could that be contributing to these numbers? And I suggest to you that it might be, because to some extent, maybe this outcome is explained by pioglitazone preserving people from death, myocardial infarction, acute coronary syndrome, stroke and leg amputation to be available for coronary and leg revascularizations, because if you're dead, you can't have them, etc. And furthermore, if you believe that pioglitazone reduces atherosclerosis, improves what's happening inside arteries, as suggested by these papers, what was it used to happen in those days, 2005, early 2000s? What did the vascular surgeons and cardiologists do if they were thinking of doing a procedure? They did an angiogram. It's not like now, you go in, within an hour of it happening. They did an angiogram, they waited for the result, they looked at it, and they thought, I reckon I could get through that. And then they would do their procedure. Now, supposing the artery was being opened up by the pioglitazone, and now you're going to get more of them where the vasculature's go, I could get through that, and then he does his procedure. And so it might be that the impact of pioglitazone arterial zone made the coronary and leg arteries more amenable to revascularization procedures. So that could be the case and could be the reason. And so basically, my thesis is that this primary composite endpoint doesn't help. You just have to ignore it and look at everything else. So, my suggestion to you is that the accumulated evidence suggests that pioglitazone reduces cardiovascular death, myocardial infarction and stroke by slowing down or even reversing the atherosclerotic process. If we compare and contrast EMPA-REG and proactive, this is the 3-point MACE, both of them separating hazard ratio, very similar for both of them. But look at this delay in separation with proactive, to me, working with the idea that the atherosclerosis is improving, whereas this is an entirely different mechanism, as we've discussed many times today. And let's look at myocardial infarction. We've always suggested pioglitazone has an impact, whereas empagliflozin no impact. And even more so, stroke, pioglitazone an impact, and empagliflozin no impact. Separation of the lines, I've already mentioned, instant for empagliflozin, a bit of a delay for pioglitazone. And instant separation of the lines for cardiovascular death. So I think all this comes together to say the EMPA-REG outcome trial suggests that empagliflozin reduces cardiovascular death but does not reduce either stroke or myocardial infarction, signifying a different mechanism to that of pioglitazone, more hemodynamic in nature. And now let's get to leader against EMPA-REG. Similar hazard ratio, but a bit of a delay there in the separation of the lines with leader, whereas the instant one with EMPA-REG. And all of the items being pulled across in leader, but more so death, cardiovascular death, and even more so death in EMPA-REG. And looking at myocardial infarction, yes, less, but not statistically significant, perhaps less impact on myocardial infarction compared to pioglitazone. And again, with stroke, some separation, not statistically significant, whereas we have big separation with pioglitazone. And hospitalization of the heart failure, liraglutide, no effect, whereas a big effect with empagliflozin. And we heard earlier from Dan Drucker a vast number of ways that liraglutide might be having this effect, perhaps some atherosclerosis impact, but maybe a whole stack of other things as well. So I think the LEADER trial again shows a bigger impact for liraglutide on cardiovascular death than on stroke and myocardial infarction, but in contrast to empagliflozin, no impact on heart failure. This suggests different mechanisms for liraglutide to both pioglitazone and empagliflozin. So 3 agents having different good effects on cardiovascular outcomes by different methods. So what about the potential for these agents to complement each other? So let's look at the side effects. Pioglitazone, fluid retention and weight gain. Just want to make this point that it isn't heart failure that's worsened with pioglitazone. It has no effect on the myocardium, but it increases fluid retention. So if you've got a failing myocardium, it may not be great. Empagliflozin genital infection, liraglutide GI side effects. What about this? Reduction in heart failure, fluid retention. Could these agents be a match made in heaven? You know, one improving the side effect of the other. What about weight gain versus weight loss? Again, potentially a match made in heaven. And indeed, there is evidence. This is actually with canagliflozin, in which pioglitazone and fluid retention and weight gain associated with pioglitazone mitigated by canagliflozin. And again, liraglutide causes weight loss, pioglitazone weight gain. Again, could this be, once more, a match made in heaven? Liraglutide annihilating the weight gain problem of pioglitazone. And this is a great study by Ralph DeFronzo, the EDIC study, in which he took patients with poorly controlled diabetes and randomized them into the traditional approach, which he described as sequential escalation through metformin, then sulfonylurea and insulin, versus starting the patient all at the same time on metformin, pioglitazone, and a GLP-1 receptor agonist. It was, in fact, twice-daily exenatide that was used. And the bottom line was that the early use of triple therapy resulted in a lower hemoglobin A1C, much less hypoglycemia, and weight loss, whereas the traditional approach led to weight gain. So weight loss was the overall impact of pioglitazone and exenatide together, suggesting that this is a reality, that the GLP-1 can improve the weight when they're used together. So I would suggest you, in conclusion, And this is one of several papers that myself and Ralph de Franz have written in the British Journal of Diabetes, but this is one that came after LEADER, that the combination of metformin, pioglitazone and pagliflozin, brackets and or canagliflozin, and liraglutide now appears to be the optimum cocktail of medications for improving both glycemic control and cardiovascular outcomes in people with type 2 diabetes at high cardiovascular risk. The evidence we have today suggests that these agents in combination could complement each other to prevent cardiovascular events and save lives. Okay, thank you very much.